Right. So, presume everybody's done. Start filtering back in. I see. I was gonna go over it. I was just reminded about the homework assignment that Dalton has to do for whatever it was. We can spend a couple minutes then, tonight, tomorrow, and complete it. In particular, that last question on the sheet there. Like that at the beginning of class. And number 4 is what I'm really particularly interested in hearing from you guys. All right, everybody get this handout? Am I missing? Oh, sorry. What you see on this sheet of paper is, publication isn't necessarily all that recent, but what it does do is list out various beta lactamases by molecular class. That's the Ambler classification that I like to use, and I think that's pretty pervasive in the IV literature. People will talk about Ambler class A, B, C, and D. And I think that's the one that I want you guys to focus in on and start to develop some familiarity with. I'm not asking you to memorize, all the different class A enzymes, all the different class B and C enzymes, but I think if you're able to talk about them and understand like what a particular class C enzyme is going after from a hydrolysis perspective, what that does is then that informs, your recommendation on what you should or shouldn't use for therapy if you know that ahead of time, a priori, before you're starting to treat somebody. The Bush-Jacobi classification, again, to look at all of those, that gets pretty circuitous. I wouldn't recommend using that. I think that's pretty much relegated to the research realm. Okay? So, and I highlighted molecular subclass. It starts off with C, A, D, and then ends up with D. the substrates. Again, too, these beta-lactamase enzymes have a particular substrate specificity. Some of them only want to hydrolyze this particular beta-lactam. Others want to hydrolyze this and this. And then again, we have these other lactamases that don't care. They're going to hydrolyze whatever you throw at it. And those are the ones that we get really, really concerned about if and when a patient presents. So the next column over, inhibited by. So CA stands for clavulanic acid. We haven't gotten to that yet. And then TZB stands for tazobactam. And so these are some classical beta-lactam containing lactamase inhibitors. And the classical agents, clavulanic acid, sulbactam, tazobactam, these typically retain good activity against most class A beta-lactamases. All right. And so to kind of go through this list, you'll see this class A enzyme is inhibited, this class A is inhibited. But then you start to get to a point where all of a sudden these classical inhibitors aren't doing anything to the class A enzyme, in particular the carbophenamases and some of the ESBLs as well. So that gets a little bit concerning. The next thing over, what is EDTA? EDTA. Doesn't have it on the key down below. Oh, anybody familiar with EDTA? Ethylene diamine tetraacetate. So it's a reagent that we often use in the lab to chelate particular cations. All right, so it's got a lot of negative charge around it, and what it has the capacity to do is chelate divalent and trivalent cations. I use it in the lab to help purify a reaction. When I want to get rid of copper, I'll throw EDTA in there and it'll quench the copper and then I can wash it away. But what's the relevance of EDTA as an inhibitor for beta-lactamase enzymes? And what lactamase enzymes have zinc? Thoughts here. What molecular class has zinc in the active site? A, B, C, or D? It's B. Right, so the Ambler class B lactamases follow beta-lactamases. And what we've shown is that when you treat a culture with EDTA, what you can do is you can quench or literally remove that zinc from the active site. And if you do that, then the enzyme doesn't have the capacity to position a water molecule and activate a water molecule to serve as a nucleophile to hydrolyze beta-lactam.
So this EDTA, is it toxic?
So small amounts of EDTA aren't going to do much to anybody. Orally, maybe even a little bit intravenously, as long as it's sterile. But what is unknown is how much you actually have to give to a human, to treat an infection. Because think about this for a second. What's your favorite infection? Pseudomonas. Where? Growing where in the body? The GI tract. Okay. In the GI tract, let's take it one step further. Let's say not in the GI tract. Let's say the abdominal cavity. Okay. It got through the GI tract, and now it's affecting the abdominal cavity. You have Pseudomonas growing in your abdomen, and you're going to treat that with an antibiotic. If you give an antibiotic orally, think about everything that antibiotic has to do, where it has to go, right, to get to the site of infection at the right concentration, okay? Or intravenously, pump antibiotics through a vein, it has to distribute throughout the body, which isn't that big of a feat, but then it has to penetrate the tissue, get into the abdominal cavity, to the site of infection to kill that organism, right? Does your drug do that? Will it get there? Will it get there at a high enough concentration to which it's going to kill the offending organism? Okay, that kind of study I don't think is known with something like EDTA, let alone we have a lot of divalent, trivalent cations that we require for a variety of metabolic processes. So to give a chelator like this would be a risky business, so to say. Right. What I will tell you though is that there are some interesting beta-lactamase inhibitors coming down the pipeline right now that have the capacity to chelate that zinc ion, yet not do too much damage to the host. So Anorexia, I think is the name of it. You'll see that in your practice time, because it inhibits the class B enzymes as well as a variety of other A and C enzymes, maybe even D, I think. Okay. All right. Defining characteristics, again, too, I highlighted a couple ones that I think you should review. I omitted. You see where the first row of class D enzymes occurs? The first D that's highlighted is oxacillin, OXA1, OXA10. The second D that is highlighted is an extended spectrum cephalosporinase, OXA11 and 15. And then the next one down, I should have highlighted that, but I didn't. Carbapenems. And it gives you OXA23 and then OXA48. These are some carbapenems. OXA48 is a concerning one, and it has varying hydrolytic activity against, say, imipenem versus meropenem. So sometimes, if you're looking at the literature and you find a paper on OXA48, you know, the carbapenems typically do a nice job, but their ability to achieve a clinical cure is going to be somewhat variable from agent to agent, depending on what OXA enzyme might be present. Okay. All right, so again, just start to look this over and become familiar with the terms, with the enzymes and their substrates. I think it'll benefit you moving forward. Okay. All right, resistance mechanisms for beta lactams by quick way of review. Obviously, for gram-positive organisms, beta lactamases, a la paper here, is a major mechanism of resistance. How else do gram-positive organisms get around the presence of a beta lactam? What would be another resistance mechanism? Porins. Porins are mostly going to be for the gram-negatives. Gram-positive organisms have a thick cell wall and then a cell membrane, but no outer membrane where the porins would exist. So porins, we're going to put over here. Got a little ahead of me. I'm catching up. Right. Beta lactamases, we can put that over here as well. Right. How else do gram-positive organisms circumvent the presence of a beta lactam? What can they do?
Change the penicillin binding protein.
They can change the penicillin binding protein. Absolutely. And there's two good examples that I want to just kind of focus in on. Right? I'm going to put penicillin binding protein alterations. And one good example for that is strep, where strep mutates its penicillin binding proteins such that those enzymes become low affinity penicillin binding proteins for classical drugs like penicillin and amoxicillin. But we get around that with the dose. We can escalate the dose, all right, for those classical agents, or use a cephalosporin that actually might have higher affinity for the penicillin binding protein. Okay. And then the other one is kind of where we left off on last week, Wednesday, MEK-A expression. Okay, MEK-A. And if an organism undergoes some genetic analysis to reveal the presence of the MEK-A gene, what are we going to call that organism? Especially if I tell you it's a Staph aureus. MEK-A positive Staph aureus is collectively known as, right, MRSA. Okay. All right. That's not too bad. It's legible, right? It looks worse on my screen. I can promise you that. Okay. And then that's where we kind of left off last week. All right. So again, too, we talked about altered penicillin binding proteins in strep. And then we talked about the rationale behind oxacillin and nafcillin.
We certainly know that Staph aureus has the BLAZ gene, which is responsible for producing a beta-lactamase called PC1. That's listed on that table somewhere. And that particular enzyme has nice affinity for penicillin derivatives, benzylpenicillin in particular. But what has been discovered over time is that if you elaborate or increase the size of the substituent coming off the 6th position in your beta-lactam, in your penicillin, what you can do is you can protect the beta-lactam bond from that particular beta-lactamase, and it will retain activity. It will continue to inhibit peptidoglycan synthesis. That's what nafcillin and oxacillin achieves. Again, this bulk back here protects the beta-lactam bond from the hydrolytic effects of the PC1 gene, okay? Methicillin, bulky group. Nafcillin, bulky group. Oxacillin, bulk. Dicloxacillin, bulk, okay? That bulk also might impair the substrate's ability to enter into the active site. All right, so a little bit of extra size on this back end here and here might deny access to the penicillinase binding site, okay? All right, but we did say that the MECA gene doesn't really care so much about what size the molecule is, especially coming off that 6th position. So what the MECA gene does is it encodes for a protein that we call penicillin binding protein 2A, right? This is a variant transpeptidase enzyme that has the capacity to synthesize peptidoglycan despite the presence of beta-lactams. Okay. So organisms like MRSA that express this particular enzyme are successful. I'm going to spend a second talking about this because I think it's important and I think it's very interesting. So I want this to represent just your garden variety penicillin binding protein, we'll say 3, okay? And penicillin binding protein 3 has that critical serine residue, serine 17 or whatever it is. And your beta-lactam, like your penicillin, can come in and serve as a substrate and inactivate penicillin binding protein 3, okay? MECA is a little bit different. Structurally, it's a little bit different. So here is the active site. Here's our serine 70-ish. Okay. And then off to the side, we have this allosteric site. And so there's an accessory site on penicillin binding protein 2A that has to get activated, that has to get stimulated. When you have that stimulation or that activation here, what that ultimately does is causes a conformational change in the enzyme active site, which separates or pulls apart this protective barrier in the enzyme active site, and that serine residue all of a sudden makes itself accessible for the process of transpeptidation. Okay, I'm going to delete this and do it again. All right, I don't know if any of you are copying this down or not. Make it a little bit bigger. Does that blue show up okay? And here's our serine residue. Here's your allosteric site. What happens is when you have an agent, change it to a cephalosporin. Cephalosporin can come in, bind into the active site, but if the serine is not revealing itself, if the serine isn't exposing itself for nucleophilic attack, the cephalosporin will come in, it might bind for a minute, it might leave. It's not inhibiting the enzyme, okay? If peptidoglycan is coming in, peptidoglycan has the ability to trigger this allosteric site. And when that happens, the serine residue pops up. It can then attack the alanine residues on the C-terminal side of peptidoglycan, activate that C-terminal side, and then get attacked by the pentaglycyl unit to catalyze the formation of the enzyme, okay? Right. So the trick here is to figure out how do we convince penicillin binding protein 2A that we are resembling peptidoglycan enough such that it wants to come in and attack us, okay? And that's been the mystery for a long, long time. It's been the mystery for a long, long time. Do you know of a drug that might be successful at doing this? Julian, what is that drug? Vanco? Not necessarily Vanco.
Remember, we haven't talked about Vanco. Vanco doesn't go into the active site and inhibit the serine residue. You're close. Think MRSA drugs. Vanco is one of them.
Tell me another drug for MRSA. Don't say daptomycin. Linezolid, good. Also useful for MRSA, but we're going to learn that linezolid binds into the ribosome to inhibit protein synthesis. Okay, another one.
Cephalin,
What is it?
Cephalin? Cephalin or is it Cefazolin?
Cefazolin, good. So cefazolin, cephalosporin, drug of choice for MSSA, methicillin susceptible Staph aureus, but our staph here is expressing the MECA gene, so it's MRSA. Do you know of a beta-lactam that inhibits MRSA? Ceftaroline, there you go. How does ceftaroline accomplish this? What does ceftaroline do? Ceftaroline binds to that allosteric site, and then it also binds to the active site. It triggers that allosteric site with its side chain coming off the 3 position, and then that allows for that serine residue to say, come on in, and boom. That's how we inhibit it. We'll see ceftaroline in a little while. All right, good. Could you write this out in a paragraph form? Could you explain MECA in a paragraph? I think so, okay? If not, just think about it, all right? We'll go over it again, don't worry. Questions? All right. Semisynthetic penicillinase resistant penicillins. Again, we're still talking about penicillinase resistant penicillins. These are the drugs that are anti-staphylococcal penicillins. Cloxacillin and dicloxacillin, you mentioned dicloxacillin the other day, so it's still relevant, okay? Just by quick survey of the structures, here's dicloxacillin, here is oxacillin, and you can see the structural similarities that exist between the 2 molecules. Dicloxacillin is a little bit heftier because it has these 2 chlorine substituents at the 1 and 6 position, or excuse me, the 2 and 6 position, the meta positions, or ortho meta para. You tell me. Ortho meta para, ortho position. When you have these big chlorines sticking out at those 2 sites, really what that does is that prevents free rotation of that ring. It's going to start colliding into electron clouds here, and then probably from that isoxazole ring. So dicloxacillin is a little bit bulkier relative to what you see with oxacillin, and then just those two protons. But regardless, a significant amount of bulk protecting the beta-lactam bond from the PC1 enzyme. The PC1 enzyme coming from the BLAZ gene that most Staph aureus have. If it's BLAZ positive, we pretty much refer to that as MSSA. If it's MEC-A positive, we call that MRSA. Okay. What percent of staph isolates retain sensitivity to penicillin? Have you come across any? Very small percentage, if any at all. Very small percentage. Kind of like the diamond in the rough. I mean, if you find a staph isolate that's susceptible to penicillin, you probably went back in time. Let me know how you did that. There's some stock I want to buy. But I don't even know if the lab tests. Do they even test Staph aureus isolates for penicillin susceptibility? Do they? All right. I don't know if I need to say too much about dicloxacillin. Again, too, if you see dicloxacillin, it's most likely a staph infection. It will kill strep, but mostly going to be for staph. Little metabolism. Like most penicillins, it goes out in the kidneys. So we've talked about penicillin, garden variety penicillin, Pen G, Pen V. We've talked about anti-staphylococcal penicillins, all right, oxacillin, dicloxacillin, nafcillin. And the middle group there, oxacillin, dicloxacillin, again, those are penicillinase resistant. We're going to shift gears and talk about some penicillinase sensitive, broad spectrum penicillin derivatives. Right? Piperacillin, and then a classical agent that's, I don't even think available anymore, ticarcillin. These were what we called ureopenicillins. Because when you look in their side chain, in particular with piperacillin, there's the equivalent of a urea molecule embedded in this long water-soluble side chain. So it's referred to as a ureopenicillin. Piperacillin is pretty much the only one relevant. And I don't even know if piperacillin by itself is available anymore. Piperacillin is probably not even being produced these days. I think everything that you're going to see along the lines of piperacillin is going to be in combination with tazobactam in the form of Zosyn. Piperacillin, its claim to fame, I guess you could say, is its activity against Pseudomonas. It was an anti-pseudomonal penicillin. It has very, very good penetration through Pseudomonas porins. Right? That's one of the barriers to successful treatment with beta-lactams and Pseudomonas. Pseudomonas has very finicky, very picky porins. Ironically, when you look at the structure of piperacillin, it's very, very extensive. It's long and it's water soluble, and it tricks these porins into thinking that it's something useful. As such, they pass through the porins and can inhibit the penicillin binding proteins in Pseudomonas, provided they are expressing the right beta-lactamase, because they are sensitive to beta-lactamases. Incidentally, I'll just make mention, there's two drugs that we'll talk about, amoxicillin and ampicillin. These are aminopenicillins. They're still water-soluble beta-lactams, but Pseudomonas is intrinsically resistant to amoxicillin and ampicillin, and that largely is due to the porins. The porins do not allow ampicillin and amoxicillin to penetrate through and get into the periplasmic space. We won't worry about ticarcillin. Here is piperacillin. Here's the urea that I was making mention of. So this is the classical pharmacophore that you see with the penicillins. And then you have this rather large side chain coming off that sixth position. I mean, look at that. That's pretty extensive. There's a lot of molecular weight represented here from this side chain. In fact, if you add it all up, it's going to be larger than you see for napsilin or methicillin. So the question then all of a sudden occurs, why does that side chain not protect that beta-lactam from lactamases? What is it about that side chain relative to napsilin or dicloxacillin? Yes,
Is it the rotation because it can't turn down?
absolutely. Good. I like the way you're thinking. That side chain, despite its size, is nothing more than a dog's tail. Right? It can flap around and rotate here and there, and it is not locked in a particular conformation that's going to afford it protection. Okay. And so a variety of penicillinases, beta-lactamases can hydrolyze that. It's nice because it has a lot of water-soluble characteristics associated with it. It's nice because it facilitates porin passage, but it's not perfect because it is susceptible then to hydrolysis by the lactamases. And that's why we guard piperacillin by administering it with an inhibitor. They undergo minimal metabolism. They go out in the urine. Pretty much with the exception of what napsilin, Dr. Lewis, all the penicillins need some type of adjustment for renally impaired patients. So that's just something that should always be on your mind. You know, you see this order come across, first thing you need to do maybe is look at allergies and renal function. As I've alluded to then, you know, piperacillin by itself back in the day had decent coverage against some gram-positive organisms. It had decent coverage against some gram-negative organisms. But what we can really do to enhance its spectrum of activity is combine it then with a beta-lactamase inhibitor like tazobactam. And adding on tazobactam essentially reconstitutes coverage against Staph aureus, because tazobactam will inhibit the PC1 enzyme that Staph aureus likes to make. Tazobactam will inhibit a variety of beta-lactamases that anaerobic organisms might be producing, so that can contribute to its anaerobic coverage. And then tazobactam is going to inhibit a lot of class A enzymes that other gram-negative organisms are producing. Okay, so Zosyn ends up being a pretty broad spectrum agent. Okay, it's got a lot of utility, and that's probably why it's on tap at most hospitals. And then sulbactam and then clavulanic acid again to pair sulbactam with ampicillin. Clavulanic acid gets paired with amoxicillin to give you augmentin. Unison is the beta-lactam, beta-lactamase inhibitor combination that incorporates sulbactam. And then just a little bit about these lactamase inhibitors, these classical ones. They themselves aren't necessarily antibiotics by and large. Tazobactam, sulbactam, clavulanic acid, if you just administered them as the sole agent, you're not going to achieve a clinical cure for 99.999% of infections. I think the caveat, of course, is going to be what organism. Sulbactam is of principal interest. Sulbactam. Sulbactam by itself. What organism would you use sulbactam? Acinetobacter. Acinetobacter. So I can't think of any other organisms where the inhibitor component by itself is really of principal interest. So Acinetobacter is the only one that comes to mind. And even susceptibility to that is diminishing. So that's why this is here. These inhibitors end up being irreversible inhibitors of beta-lactamase. So they give themselves up, they bind into the beta-lactamase active site, they get attacked by the serine residue in that lactamase active site. They open up and then covalently modify. They irreversibly inhibit that beta-lactamase. And then that ought to then protect the beta-lactam of interest. And then here are the structures. You can see they all have a beta-lactam bond, a beta-lactam ring system, and then they open up and decompose in various ways to inhibit the enzyme of interest. Class A enzymes are the most sensitive to these inhibitors. They won't touch class B enzymes. So class B, the metallo-beta-lactamases, are not sensitive to these guys. And then class C and class D most likely aren't going to be sensitive to these classical inhibitors as well. How well that's represented on our handout. You can see class C doesn't even really touch them. The class A, yes. Not all class A's, incidentally. And for the class B enzymes, it's listed as variable. So it's hit or miss. And then that takes us to the last topic, the aminopenicillins, ampicillin and then amoxicillin. Amoxicillin is pretty much your go-to aminopenicillin for oral administration. Ampicillin, with or without sulbactam, is still used in the hospital for intravenous administration, in particular when you have a strep infection. But we get excited about a drug like amoxicillin because it has very good bioavailability relative to Pen G and Pen V. The side chain is fine-tuned a little bit such that the isoelectric point, it's optimized for enhanced oral absorption. We put a hydroxyl group at the para position on the ring, and all of a sudden that enhances its bioavailability. But what's more interesting too then is the presence of this amino group in the side chain. So one of the liabilities of the penicillins is their propensity to hydrolyze in the gastrointestinal tract under acidic conditions. And just to show you really quick, so here's an R group, and then what can happen is in the GI tract under acidic conditions, the carbonyl groups can grab onto a proton, have a positive charge, and that creates a dipole at this carbonyl carbon. And then what can happen you can have a developing negative charge on the carbonyl group in the side chain. And then that can go on and attack the carbonyl carbon, thereby opening up the beta-lactam ring and degrading your penicillin. So this is typically what happens with penicillin G, which is why we don't give it orally. It happens less with penicillin V, and it happens even less with something like amoxicillin. And the reason for that is that under acidic conditions in the stomach, that amino group in the side chain is serving as a base, so it grabs onto a proton. It has a positive charge all of a sudden, and that positive charge is actually going to pull electron density away from the carbonyl groups in the side chain. That makes it very, very difficult then for a resonance system to develop in the side chain. The attack of that carbonyl in the side chain on the beta-lactam ring. So this enhances their oral bioavailability, right? Because the ability of this system to develop is decreased. And that is suppressed, okay? I'm not concerned that you're familiar with the mechanisms. I'm not going to ask you to reproduce the mechanisms on an exam. But when you hear that a drug like amoxicillin has enhanced bioavailability and stability relative to something like Pen-G or Pen-V, this helps to answer that question in your own mind. What are you? You are a pharmacist. What do you dispense? Drugs. What are drugs? Drugs are chemicals. You're a drug expert, you're a chemical expert. Sorry. Just the way it is. 74 to 90% for amoxicillin, that's the range. So that's pretty good. Widely distributed, so they get pretty much everywhere in the body. And then they will get into the central nervous system, especially when somebody presents with a meningitis. So when the meninges are inflamed and the blood-brain barrier becomes a little bit leakier, these drugs have an increased ability to cross the blood-brain barrier. Do we achieve a high enough concentration to treat a meningitis? Oh, that's going to be dose dependent. Okay, so if we give the right dose, intravenously in particular, then we'll achieve enough to cure that patient of their central nervous system infection. They undergo little metabolism, and then again, too, in the renally excreted. Now, with the penicillins, I don't worry too much about kinetic drug-drug interactions because they don't really undergo oxidation in the liver by CYP enzymes. But you should be aware of some pharmacodynamic drug interactions that might be occurring. Some of the interesting ones too, again, when we were dispensing a lot of warfarin, there's a component of vitamin K that gets produced by your gut flora. And that vitamin K contributes then to somebody's stability on a drug like warfarin, okay? So you titrate the INR, and you titrate the INR based on the absence of an antibiotic, and you're accounting for what vitamin K the gut flora is producing. Then you have an antibiotic administered to a patient, and then they wipe out that GI flora for 10 days or whatever. Does that have any significant impact on warfarin? Does it alter the INR? Are they at increased risk for an adverse effect? And that vitamin K isn't there anymore, and you're still giving the same dose. Something just to think about. Fortunately, I don't think we use that much warfarin anymore. The other one that comes up from time to time, and can't really say how clinically relevant it is, but it is a drug interaction, is the whole birth control antibiotic issue. Okay, so again, bacteria are responsible for participating in some enterohepatic recycling of hormones. Right? They modify the hormones, they help the hormones get reabsorbed. Is there something going on all of a sudden when you put an antibiotic on board and that hormone isn't getting taken back up into the body? Does that suppress the ability of the birth control pill to inhibit ovulation? And if you look in the literature, there's probably a lot of case reports where that has been suggested to have caused maybe an unintended pregnancy. Dr. Lewis, do you have any other examples of interesting beta-lactam drug interactions? Anything come to mind that you've seen recently? Not that I've seen any of these recently, but just fodder to talk about. I'll come back to you if you come up with anything, let me know. Okay. All right. Ampicillin and amoxicillin, aminopenicillins, good bioavailability, but they are penicillinase sensitive, beta-lactamase sensitive. Okay, so you're not going to use ampicillin or amoxicillin to treat a staph infection. But if you couple ampicillin or amoxicillin with the appropriate beta-lactamase inhibitor, then you will get some activity. You'll get some efficacy at that point. Okay. So clavulanic acid with augmentin. Okay, fine. Gram-positives, including Staph aureus, not MRSA. Gram-positives, including strep, albeit if you know it's strep, you don't need the beta-lactamase inhibitor. Gram-negatives, in particular gram-negatives that might be causing upper respiratory tract infections. Oh, and anaerobes. Anaerobic coverage as well. Well, that was fun. What questions or concerns do you have about penicillins? Who's lost? You're lost or you have a question? Or both? Yes.
So for beta-lactam inhibitors, is the purpose of getting rid of the side chain to effectively have the bacteria recognize it as an antibiotic? So it intentionally attacks that over the intended antibiotic?
Yeah. So I don't think you can necessarily dictate, which molecule is going to find its way into the beta lactamase active site. Okay. If you take augmentin, for example, right? Here's your amoxicillin, here's your clavulanic acid, and then here is a beta lactamase. If the amoxicillin comes in first, it's going to get hydrolyzed, and then the enzyme is going to get deacylated, and it's going to continue to function. Okay. Ultimately, though, and what you hope is that the clavulanic acid makes its way into the active site of the beta lactamase. When the clavulanic acid gets attacked by that serine residue in the active site, it'll open up the ring, but it doesn't get deacylated. It doesn't get regenerated, that being the serine residue. So it's effectively inhibited until it goes away. And the bacteria would have to make more beta lactamase in order to achieve or overcome the presence of the drugs, is what it boils down to. Okay, so essentially, you want your beta lactamase inhibitor to get recognized and taken up and attacked by the beta lactamase enzyme. Right? You want it to get inhibited as fast as possible. Okay, good question. The quandary then is the fact that we have these non-covalent beta lactamase inhibitors. Now, we've got a lot of drugs out there now that will bind and tie up and inhibit the beta lactamase, but then they come off and then regenerate, get spit out, but then can come back in and bind. Avibactam is an example there. Avicaz, right? Ceftazidime and avibactam. Avibactam does not covalently inhibit the enzyme. Right? It's transient. It comes on, binds, forms a complex, comes off, and can come back in and bind, and then come off, and so on. Okay. Good question. Other questions? How much time do we have? Is that like 10 minutes? Is that about right? We're going to start talking about cephalosporins. Cephalosporins are really cool. There's a lot of them. They get grouped into these things called generations, which I don't know. When I was growing up in pharmacy, they made us just memorize the generations and what drugs were in each generation. And I don't necessarily think that's a bad thing. But what I do think is important is that you have an understanding of what type of coverage each generation affords you. Okay. And I don't know, how did you memorize or learn them or memorize them, Dr. Lewis? I mean, you kind of agree with that, or is there a different way to kind of start siloing these cephalosporins? First generation, gram positive, second generation, crapshoot, third generation, gram negatives, and so on? Or you got a better way? You probably have a better way.
Should start somewhere.
Yeah, it's going to get more complicated. I'm going to stop bugging you. I'm sorry. Like I'm getting shade thrown at me. Right. Well, we never did answer that question from the penicillin slide at the beginning of that slideshow. But here's another one. So patients growing an ESBL producing strain of E. coli, which of the following will result in a treatment failure? Which of the following will result in a treatment failure? If you were to refer to your chart, an ESBL is what molecular class? A, B, C, or D? And then what are the preferential substrates of ESBLs? Yeah, you said it, Andy. What is it? Cephalosporins. So if you know that ESBLs like to hydrolyze cephalosporins, can you right now look at those 4 molecules on the screen and pick out the cephalosporins? Or will you be able to by the end of this week too. We got a vote for B and we got a vote for C, and that's correct. So if B and C are cephalosporins, what is A and what is D? Carbapenems, right? So B and C aren't going to do us much good, but A and D represent drugs of choice. Drugs of choice for ESBL producers. We won't get through all of this today, but we'll start it. Cephalosporins, carbapenems, and then a variety of other cell wall synthesis inhibitors, keeping with the same objectives. Again, too, I want you to look at the structure, right? I want you to recognize the pharmacophore, but then I want us to start associating certain families or certain generations with specific coverages. And along the way, I'm going to tell you what structural features I think are important from a clinical perspective. Right? We'll get into the sulfonamides as well at some point. Okay. Where did the cephalosporins come from? How were they identified? Much in the same regard as previously discussed for penicillins. There was a sewer fungus, a Cephalosporium acremonium. Sewer fungus. Somebody decided to pull it out and then grow it and then isolate some metabolites from it and see what happens. And lo and behold, cephalosporin C was the first cephalosporin that was identified that had activity growing from this particular mold. It itself had weak activity, but what was interesting is that the cephalosporin C all of a sudden displayed some stability in the presence of penicillinases. So PC1 had a very difficult time hydrolyzing this weakly active cephalosporin. Why might that be? Well, here's the structure of cephalosporin C. And what you're going to notice is that the ring system, i.e. the pharmacophore that is represented by cephalosporins, is expanded by 1 carbon relative to the penicillins. All right. So the penicillins have a thiodiazine ring, a 5-membered heterocycle. The cephalosporins have a 6-membered ring, a dihydrothiazine ring. This dihydrothiazine ring is again annealed to the beta-lactam ring. And that's where the cephalosporins come from. And you think 1 carbon, we're going to expand this ring by 1 carbon. What is the functional consequence of doing that? Well, that 1 carbon expansion actually decreases the affinity of the cephalosporins for that penicillinase. Okay, so it's kind of interesting. 1 carbon makes it more difficult for these drugs to get into the penicillinase active site. As such, they're more stable. The cephalosporin C is shown on the screen here. Again, weakly active. The side chain isn't doing anything for anybody. And what was discovered is that, again, we can enzymatically remove this side chain. End up with something called 7-amino cephalosporanic acid. We have this amino group coming off the 7 position. And then to that amino group, we can add multiple different side chains to confer stability to beta-lactamases, to enhance the spectrum of activity, to maybe modulate the kinetics of the drug, and so on. So most of the cephalosporins that were developed were done so in a semi-synthetic fashion. Mechanistically, these drugs do the exact same thing that the penicillins do. They bind to the active site of the penicillin binding protein. The ring opens up under the attack of a serine residue, and you form an acyl enzyme intermediate that does not get displaced by a pentaglycyl unit or a diaminopimelic acid derivative from gram-negative organisms. And a lot of that is because, again, the bulk of the ring is preventing the deacylation or the attack from the adjoining peptidoglycan precursor site. Structure activity, SAR. You already know that we need to maintain the presence of this beta-lactam ring at all costs. We know that if we open up that ring, we lose all activity. Right? So a 6-membered ring annealed to a 4-membered ring creates less ring strain on the beta-lactam ring as compared to a 5-membered ring. Right? So having a less ring strain induced by the 6-membered cycle increases the stability alone. Okay. Coming off at the 2 position, we have a carboxylic acid. We know that that's important because that does mimic the sequence of D-alanine, D-alanine, and that actually establishes some type of bond with, as a lysine residue in the enzyme active site. At the 3 position, there's just an acetate shown here, and that's very general. And some of the cephalosporins have an acetate as the side chain at 3 position. But when you start to survey the structures of some of the latter cephalosporins, what you're going to come to realize is that you can modulate kinetics with substituents at the 3 position. And that's important because that could be the difference of giving a cephalosporin every 6 or every 8 hours versus just once daily. Then these other concepts, affinity to the penicillin binding protein, affinity to the lactamases, and then permeability issues are all relevant when we talk about the 3 position and modulating different moieties at that 3 position. Okay. We'll talk more about that on Wednesday. I think we're good for now. Spend a couple minutes between now and Wednesday, see if you can find anything interesting from an investigational perspective. Even if it's a existing drug that's getting repurposed for a different indication, I think that would be cool to hear about. Okay. And as always, if you have any questions or concerns, just let us know.